Good morning from
Good
the
morning.
room PRD at the Montreal Heart Institute. So we have an interesting case for you today, and we're hoping that'll stimulate a lot of discussion for you guys. Sorry, just trying to get my slides to go. Can we see the next slide, please? So our case objectives today, we're going to let you guys talk about the indications for transcatheter aortic valve implantation, discuss potentially your choice of device. We'll show you what we've decided to use for TAVI, and then discuss strategies for management of potential complications occurring either during or following the TAVI. So our patient today is an 80-year-old male. He has severe symptomatic aortic stenosis, dyspnea on exertion. He's class 3 and now has symptoms of class 4. His previous history includes hypertension, dyslipidemia, atrial fibrillation, anticoagulated with Coumadin. He does have a left bundle branch block, previous left leg DVT in 2012, a previous TIA, and prostate cancer treated with radiotherapy. In terms of his vascular history, he's got an abdominal aortic aneurysm that measures 3.8 by 3.9. It's infrarenal on the last CT scan. He also has a right iliac aneurysm that measures 2.8 by 2.5. He was diagnosed with a pulmonary nodule following his workup for TAVI on CT and had a PET scan that was negative. And he has coronary artery disease with previous bypass surgery, with a lima to the LAD and a vein graft to the OM. So if we can just go to the angio of his grafts. I don't know if you guys can see that.
Not yet.
No?
Oh, yeah.
You can show the
It's coming,
angiography.
yeah.
So basically what you see, he does have severe native coronary artery disease. Next image. And you can see some competitive flow in the LAD. You can just go on to the graphs, please. Next image. Okay, so here we see, this is the vein graft to the marginal, which is patent. And then we will show you the mammary. So if we can just show the mammary, please. And so this is the mammary. So it's somewhat close to the sternum, but certainly not underneath the sternum. We have Raymond Cartier with us, who's our cardiac surgeon. And the discussion, we can talk a little bit about in terms of surgical backup, et cetera. So we'll go back to our slides. So just one further note, he does have chronic renal impairment and has a creatinine of 139. So on his transthoracic echo, he has an ejection fraction of 45%, has a mean aortic gradient of 52 with an aortic valve area of 0.56. No significant aortic regurgitation. Does have 2+ MR and does have 3+ TR, and his pulmonary artery pressure was 37 by echo. So we did a CT scan, and we analyzed using fluoro-CT to get the optimal size and angle of the implantation. So these are some of the images of the fluoro-CT. Can you go to the next slide? I'm not... Okay, so here you go. You can see the calcification in the leaflets. This is obviously Nick's program, which has really helped us dramatically. We no longer do aortograms to determine the appropriate implantation angle. And here you can see the area is about 456 millimeters squared. The dimensions are 20 by 28. And so this does fall in the range of an Evolute 29, and Jean-François will talk a little bit more about our strategy. And this is our implantation angle, so an LAO 13 with caudal 4. So I'll let Jean-François talk a little bit about our strategy today.
Yeah, so once again, the question was, of course, as you saw, the left inguinal mammary artery wasn't that much in the way, so the patient, could have been a surgical candidate, but at the same time, with all the comorbidities, we certainly thought he was also a TAVI candidate. And I don't know what the panel would say at this point in time about this, but certainly we know this patient would have full surgical backup should there be any complication, which of course we hope there won't be. But that was one part of the discussion. And then to go forward, there's this question of the abdominal aortic aneurysm, the right iliac aneurysm. So So as Dr. Cartier had pointed out initially, as he's also trained in vascular surgery, the idea was to come from the left so that then the bulk of the aortic aneurysm is actually shifting towards the left. So by coming from the left, you're really leaning against the aorta on the right, on its right side. So you avoid the problem. But of course, one could also comment about alternate access. Is this something that we should have, thought about from the get-go or oriented ourselves towards? Another point is the aortic calcifications and whether or not we should pre-dilate or not. Choice of valve, we certainly thought it would be better with the issue of the calcification to go with a core valve, but maybe people will have something to say about this. Worries about perivalvular leak is certainly a big point here. So I don't know about these 3 points if the panel have anything to say or any pointers for us at this point in time. Nothing is settled here, but I just told you about what our plan was. If the panel could give us some ideas, that would be great.
All right. Any comments so far? I think there's different interesting points. So the valve is the aortic valve is calcified. We consider it self-expanding, but patient is already having a left bundle bench block. Do we have more pacemaker with a self-expanding? Is it going to impact the prognosis of this patient? You saw that he's having at least moderate to severe TR. If you send this patient to a surgeon, is he going to fix the tricuspid valve at the time of the aortic valve replacement? Is it going to impact the prognosis? That's different. Good point to discuss, I guess. Yes.
Comment? Yeah.
Nick, yeah.
Yeah. Hi, JF. Hi, Anita. It's Nico.
Hi.
Hi. You showed nicely the calcium quantification, and I think we're coming a little bit more to terms as to how to deal with calcium quantification. Just in general, the units you were demonstrating were millimeter cubed. So in general, if you have 0 to 500, it's considered mild calcification. If you have 500 to 1,000, that's the average or moderate amount. If you have 1,000 to 1,500, that becomes severe. And if you have above 1,500, you start to get in trouble. If you look at some of the US core valve data that came out from the randomized trial, they found that the cutoff for significant paravalvular leak is about 1,100. So you guys are in the, I would say, severe range of calcification. From some experience in China where the amount of calcification is about 2 to 4 times what we see here in the Western world, I think in this patient I would definitely pre-dilate, especially if we're using a self-expanding valve.
So JF and Anita and Dr. Cartier at Sam Rutherford. So just answering, or just to respond to you, Nico, so I don't see a lot of annular calcification here, and there's no LVOT calcification. So the data that you're presenting, was that stratified by where the calcification is? Because I got to tell you, for us, I would look at this and say, yes, the leaflets are heavily calcified, but there's not a lot of annular calcification, no LVOT calcification. I agree with predilatation against the will of my younger colleague on the panel, but I wouldn't be as concerned that we'd have significant paravalvular leak that we couldn't correct with post-deployment BAV.
Right. So there's 2 things. One, we talked about the quantification, but you brought up a good point about the localization. And we know that if you have LVOT calcification that it's extruding into the LVOT, that's a risk factor for paravalvular leak. The more important thing here is also to look for commissural fusion. And if you have any of the commissures that are fused with calcium, you definitely want to predilate. So if you look at the echo, it's sometimes very difficult to see, but if you see on, maybe there's one fused commissure there. It's the fused commissures that you want to open in order to get better sealing of your valve. And if you could prevent a post-dilatation, why not?
And what would you predilate with? Would you go soft, or would you be a little bit more aggressive with your predilatation?
So here the annulus measured 20 by 28. I'd probably go with a 20 balloon.
This is a nice discussion about paravalvular prevention or characteristics that are inherent to the anatomy. The other thing that can be of concern here is the degree of eccentricity of this annulus. You could see a 20 by 28 annulus. There are some data showing that these type of eccentric annuli may be associated with more paravalvular leak, and therefore the choice of the valve could be oriented based on both the degree of calcification but also the eccentricity of the annulus, where an index, a very simple index, which is 1 minus the minimal diameter on the maximum diameter, provides you with a very simple index, and whenever you've got something more than 0.25, that may be associated with more paravalvular leak. And therefore, either PVL prevention technology or post-dilation or circularization, these issues come into play in terms of choice.
So I guess it's a great point, John. No, so would you, knowing that this patient is having like heart failure, LV dysfunction, would you consider the eccentricity, the LV function to choose potentially your valve, or?
Yes, this is certainly one type of case in our program where we would have considered a Lotus transcatheter valve here based on the eccentricity and also the potential absence of rapid pacing during the deployment for the LV dysfunction. Although we all know that most of these patients, they recover quite well from the rapid pacing, but you all have in mind the occasional case where rapid pacing has induced some stunning, and it's a bit difficult to recover the hemodynamics after.
Very great point.
So I think we're going to go ahead and let Patrick describe the echo for you, just to keep things moving on our side. So Patrick Garceau is our echocardiographer. So if you want to just talk them through some of the images you've already taken.
So I showed at the same time that you were discussing some of those images. So here you have a 5-chamber view. You see that there is mild dysfunction on the lateral wall. Under general anesthesia, the MR was about like mild to moderate, not more than this. Here you have the LVOT measurements. I did it like twice. You see that the calcification are limited to the really to the annulus. I measure up to 24 in long axis. And if you look at the AI, it was insignificant AI at first. There was a fusion of the commissure between the left and the right leaflet here that you see.
All right, and you were showing also the hemodynamic curve. I think it's an important point. Can you potentially review the hemodynamic curve with us, Anita? Yeah, I think
Sure.
we should read that like carefully before and after deployment.
So I'm just going to flush this for you. So we have two pigtails in, obviously, one in the ventricle, one in the aorta. And you can see here the mean gradient. I'm not sure what it was. What's the mean gradient? Okay, so the mean gradient was 34, and I think the important points here, if we look at the baseline LV end diastolic pressure, we're at 17.
We don't see
Just
the
to keep in
hemodynamic curve
mind.
again. Can you show again
Can
the
we
hemodynamic?
see the hemodynamics, the MATLAB, please?
Yeah.
Perfect. So here you can see the obviously significant gradient. It calculates out to a mean of 34. And then again, if we look at the LV EDP prior to the intervention, it's hovering between 15 and 17. So that's just to give us a baseline. We do know he has an ejection fraction of 45%. So I think it's important to have a sense of where the hemodynamics are before we get started. So this is where we are. I think we'll show you as well the aortogram that we've already done and where we are for now. So if we can just show the aortogram. Can we see the aortogram from today? You're still seeing the... Can we show it on the Leonardo? They don't see it. Okay, so here you can see our aortogram. So this is our view as determined by fluoro-CT. So we have nice alignment. So this is going to be our implantation view with some adjustments depending on what we see with the device. And if you could just show the fluoro check of the evolute, please. Can we just go to the next cine? So here we've just done the fluoro check of the evolute 29. So you can see that that's loaded correctly. So I'll let JF just describe the equipment that we're using, and we're just going to go ahead and put our wires in place.
So in terms of our material, well, first of all, the rest of the team, aside from Dr. Asgar, Cartier, and myself, there's, as you've heard, Dr. Patrick Garceau on echocardiogram, Dr. Jean Taillefer on the anesthesia, and then in the room, as part of the team, we have Manon, Danielle, Vicky, Zohar, and Sylvie helping us with the case today. So we had put a screw-in temporary pacemaker lead yesterday, again, just for protection in advance, knowing the left bundle branch block. We went ahead with choosing, as I said, an approach from the left side because of the issues of multiple aneurysm and used a solo path 30 centimeters. The double for close pre-closing technique that we always prefer. And then just standard sheets, we chose a small safari wire because we thought the left ventricle, without being necessarily remarkably small, is still on the smaller side. So we chose that wire. And then the question was whether or not we're going to pre-dilate. And I see, we can certainly, there's a bit of diverse opinions in the room with you guys. We personally chose, for the same reason, not a lot of calcium in the leaflet per se, not to pre-dilate. So we're going to go ahead with the valve, and that's where we're at right now.
Yes.
Okay, take the valve.
Maybe I would like to have Dr. Cartier's
Take the valve.
opinion about the approach.
get
No,
the
I'm not a TAVI person. I was just a bit surprised that with those iliac and abdominal aortic aneurysms that would still be the preferred way of deployment to go transfemoral. Probably alone in my train of thoughts, but I just
Perfect.
wanted to have Dr. Cartier's idea whether he would be concerned about embolizations from the abdominal aorta.
I think, unfortunately, Dr. Cartier doesn't have the mic at the moment. We had a bit of troubles with the AV at the moment, but when we discussed this previously, I think one of the very encouraging parts of this was that there was no intramural thrombus in the aneurysm itself. So we were just trying to, from point of view of just sheer stress of our wires on the aneurysm, we as I said, we chose the left-sided approach. But no one really thought it would be absolutely contraindicative to just doing a transfemoral approach. Unless, the panel had other thought, but of course without seeing the CT scan and again the absence
juste
of
donner un peu plus de
intramural
cadavre,
thrombus,
s'il te plaît?
it's a bit difficult to
Un
do,
peu
I
plus.
agree.
I guess the only question you might have is why not
Encore?
use the inline
Parfait,
sheath?
c'est beau.
You use the solo path, but if you're not pre-dilating, then why not just use the inline sheath?
Okay. So we're going to just start our deployment.
One
So maybe
second.
we'll let you guys discuss while we just continue working, okay? Okay.
I guess they choose to put a sheet in place because of the aneurysm. I guess.
In the aorta was really our issue. We wanted to protect the aorta. Stop there. Okay, on va faire un angio. Just
Yes,
turn
Nick,
back.
you want to intervene, Nico?
Yeah, sure. I think this is a perfect viewing angle for two reasons. The first is that the annulus is in plane, but by chance the delivery catheter is in plane as well. So they hit on the double S implantation view by chance.
Just go very slowly, okay?
So do you want just to describe briefly the feature of the valve, what you do, GF maybe, or GF?
Okay, just go very slowly.
Yeah, no problem.
And
Just
what
one
you're
second.
Maybe
aiming.
we're just gonna, we'll let you guys talk, we're just gonna try to deploy this and then maybe discuss it with you after. Just
Okay.
slowly.
Yes.
While they deploy, a lot of centers with big experience are
Keep
moving
going.
away from general anesthesia.
Slowly.
Is that something that you're looking at, or are you still, because I see there's just an anesthesiologist in the room. I assume he's intubated under sedation. Is it something, or you're planning to do in coming?
No, definitely. I think it's the thing is that we were discussing the heart team concept. If you want the full heart team involved in the case, you want to involve as much,
Yeah.
and as much people as possible. But
Bring it to 80.
I think the future for this, it's certainly to avoid general
stop there.
anesthesia,
Pressure's
the
still down, keep
minimalist
going.
intervention. But I think for us, it was one way to involve
Keep
all
going.
the art team together around the case.
You're
But
not
I think
explaining
definitely the future is to
Okay, stop
avoid
there.
the
Okay,
general
Patrick, do you wanna have a
anesthesia
look
and T
and see?
guidance because it's not required, I think.
I think it's a good point. I think it is the evolution of where this is going. At our center right now, over 50% of patients are done under conscious sedation. And I think there are pros and cons. One of the big differences is in those patients that you would think would be unstable with poor ventricular function, they seem to tolerate rapid pacing, deployment of the valve, much better than under general anesthesia. I'm not sure why. But the downside is that you don't get the transesophageal echo.
La pression est juste à
Yeah, I mean,
60.
the group here really are the national
légèrement
leaders
pas trop.
with regards to that. I mean, Anita and Raoul and now Reda, you've all been doing conscious sedation really from the get-go, but have pioneered this technique.
Okay, so we're just going to show you the echo. So Patrick, if we could just talk to them about what you see in terms of AI.
Yeah, so here you see in short axis, so there's, I would say, like mild AI on the posterior side.
Peux-tu aller un peu en haut à D? Juste
then in
attendre,
long
on va le
axis.
frapper, juste attendre.
Here it's insignificant. It's, I would say, like be traced to mild.
Just show me short axis, the level of the annulus. So it looks certainly like the valve is perhaps not fully expanded, and that may go back to your guys' point about pre-dilatation versus post-dilatation.
So at this point, Anita, you can still recapture the valve.
Yeah,
huh?
so yeah, we're still just under the level of the paddles. So obviously that also factors on the fact that it doesn't seem fully
Faire un
deployed.
angio 20 à 10, s'il te plaît.
Are we able to see the aorta in more than one view to see if it is fully expanded or not?
Ça semble s'affouiller un peu plus que tu traces.
Ouais,
Juste d'avoir un
mild.
peu de haut à D.
Ouais.
Juste faire attention, Patrick,
Ouais.
je viens vers nous.
The positioning looks nice there,
Ah,
but it
juste
does
avoir
look
un 15
underfilled,
de droite.
underexpanded down the cross-sectional.
Yep.
Yeah, correct.
Maybe a bit deep, but not too bad.
C'est bon. Tu es bien rempli, 20 à 10?
Good to go.
I guess the important here decision-making process is to decide if you are going to release the valve here
Reviens dans l'incidence de
and post-dilate after, or you're not going to accept that and then
So,
pre-dilate to come back with this valve because it's a fully recapturable valve. Nico, do you want to say
yeah,
something?
Anita,
Yeah.
it's Nico. We have time and the patient's stable, I presume.
Yep,
Yeah.
absolutely.
Why don't you try going into an extreme Mario caudal view? See what the valve looks like.
We'll try. We don't want to kill our echocardiographer, but we'll try to go a little bit more RAO. Vas-y,
RAO
Franck,
caudal,
on va
yeah.
aider.
I think you're going to realize
What
that
can't
your
cardiography?
valve is not.
Still, we can, on this view, it's, yeah, you can
Yeah,
see
keep
that
on
she's
going. Keep on going,
under
RAO caudal. You're going to see it's
expand.
probably like a pancake.
Okay. So that's as bad as RAO as we're going to be able to go. Reviens
Okay.
dans l'autre incidence. And I think we see that actually quite well on the echo as well. When Patrick showed us the cross-sectional view at the annulus, certainly to me looked quite asymmetric and under-deployed. So I guess the question is, would we deploy this as it is? I think we're all in agreement we're going to have to post-dilate. Is the height acceptable? Should we recapture this valve? Montre-moi la dernière angio, s'il te plaît. Celle-là dans la OAG.
I think the height seems to be acceptable. Of course, you want to be as high as
little deep
possible,
on
maybe
one
to avoid
side.
conduction disturbance in this patient with left bundle branch block.
So it's Sam Christian. It looks a little, I agree with you, Anita, it looks a little deep, but it's always hard to tell. You haven't released the valve, you'll get more radial force. Once it's fully released, it'll shorten a bit. But, the property of this prosthesis is you can recapture, and you don't have to recapture, just reclose and pull back a bit. Along those lines, a very nice demonstration of that was at EuroPCR with Ian Meredith,
So
where
recapture is a bit deep on one side,
where,
okay?
in fact,
Start to recapture.
just slowly recapturing it, and the valve seemed to move up just with slow recapture and then deploy. I've yet to use that but I'm looking forward to a chance to do it.
So we are going to recapture because I do feel it's a bit lower on one side. So once I think we're happy with the optimal position, then I think we're going to go forth with the post-dilatation. Keep going, the pressure's down.
Sure thing.
Pressure's down, pressure's
So
down.
as they're working,
Pressure's
sometimes
down. Keep going.
what happens with
Okay, stop
a
there.
valve deployment and then a valve recapture is that
Okay,
you
so I just want
basically
you to go very
perform a
slowly.
valvuloplasty. So sometimes the valve
Focus what your
expands a little bit
pigtails
better on
move.
the second attempt.
But
Okay,
if you
so
watch
just go
very
slowly.
carefully what happened there, it did move up a millimeter or two, even before you lost annular contact. And I think it's it's something to look for now with repositioning these evolutes.
And it's something that we see with other self-expanding devices, like Watchman, for example, for LAA occlusion. If you recapture and redeploy, it seems that when you redeploy, you end up a little bit more proximal. So it seems to be a property of self-expanding device, I
Pressure's
think.
down, keep going.
The other thing that we see is that this mechanical valvuloplasty that you're actually performing, sometimes
more.
you
Okay, that's
redeploy the valve in the exact
Okay,
same
Angel,
height, and you may
advantages.
have changed the interaction with the anatomy. And even not changing the height of the position, that mechanical
Still
valvuloplasty
deep.
with the device actually helped you out with
Do it again,
improving
Patrick.
some
Wait, wait, wait.
PVLs. We've seen that as well.
Wait, resume.
It seems that you're a bit higher, I think.
I'm not sure. I
No?
think I'm almost in the same place.
Yeah, pretty much exactly what happened.
I feel like we're exactly where we were. So just having Patrick have a
Yeah.
look around.
So let's say the AI is about the same, maybe a little bit.
No, it doesn't change it.
What's the degree of regurgitation, Patrick? Is
Yeah, I
it,
would say it's mild.
if it's mild, you can certainly consider to deliver your valve and eventually post-dilate.
Yeah, so I guess the reflection I'm doing now is, do I want to recapture yet another time to try to
Anita?
improve the position, or am I going to accept this?
Anita, I think you can maybe look at the the parasternal long axis view on echo for the depth of implant. It looks decent, and also right beneath your pigtail on the angiogram, you have a bit of calcium that you can't appreciate.
Yeah, I see
the
it.
true.
And honestly, I believe that's what's blocking me from going any higher. I seem to
Yeah.
get stuck there.
Yeah, but it may be sufficient, and I think with a post dilatation, you'll be fine at the end.
Yeah, and the valve hasn't opened fully yet.
Yeah.
So I think we're all in agreement. Ultimately, I'm not sure we can get in a better position than this, and I really believe the mechanism of the AI is the fact that we're not fully opposed. So I think post-dilatation is going to be required regardless. So we are going to deploy this here. Stop just 1 second.
Sure thing.
Pull the
I think
pigtail
another point
down.
too about placing the valve is that on the right side, you don't want to
Okay.
be that much higher on the right. You're a
Okay,
bit
just
deep
go
on the
slowly.
left, but you're also not perfectly coaxial. So once it deploys, it's going to get a bit more coaxial, and I wouldn't be surprised if that left side comes up a little bit.
Okay, let's just pull the wire in. Let's just pull the wire in.
Yeah.
Okay, push the wire out.
Yeah.
Just keep the wire in there, yeah. Okay, you want to recapture the tip first?
Certainly.
Okay, Patrick, you want to have a good look around? We're going to just retrieve this. It's not quite closed. Okay. So just keep the wire in. I'll take it out. Je prends le nucléus 25 que j'ai demandé.
I would say the
Ah,
position
just
is
1 second,
great.
please.
Sure thing.
Okay.
So, Patrick, yeah, what do you,
And then
what do you
there's
see?
still
Still
the-
mild?
Yeah, I would say there's still the regurg that is present,
It's not
mild.
Wait.
Yeah.
There, on there, wait. Okay.
I wonder if we
On
could
the
get some
pigtails,
thoughts about
okay.
the pre-dilatation from some people that have very strong feelings about doing it and not doing it. Just because I think with self-expanding valves, this is not uncommon that we see this without pre-dilatation. And when you look at the radial forces of these valves, when they're, let's say, 70, 80% deployed, the radial force is not nearly as strong as it is when it's fully deployed. So, from people who feel strongly about it, what are the pros and cons about pre-dilating and not pre-dilating?
Okay.
So, I mean, I wouldn't say that I'm opposed to predilation. Within our group, we have a bit of a spectrum. And I would say when I started a few years ago, we were predilating everybody. And when we went to not predilating, somewhat uneducatedly, we didn't predilate anybody. And now we're coming to a better understanding of the patients in whom we should. And I would say in general, we are predilating patients with, almost counterintuitively, when they have a very tight valve and bad LV dysfunction. We are predilating, but not very aggressively, accepting that they are going to get some burst pacing, which I've been surprised that they've been able to tolerate, mostly because during the deployment, when you don't predilate in somebody with bad LV dysfunction, they become unstable. And the last thing you want in that patient is to rush through your deployment of a self-expanding valve. I would say in this particular case, I probably wouldn't have predilated like they would. My decision would have been predicated on the fact there was some LV dysfunction, but it's not horrible. Although there is a lot of calcification, it's not in the LVOT and it's in the leaflets. The other thing with the predilation and the postdilation, I must admit that when my experience with both the core and especially the Evolute, when you have got to the stage where you haven't quite released it right prior to release, there are many times where it really doesn't look like it's fully expanded, and then when you release it and give it a few minutes and take the time to give it a few minutes, that's when the radial strength of the valve really becomes more apparent, and it does expand at that point, and many times by just waiting we don't end up post-dilating. I'm not sure that that would be the case here because it still looks quite asymmetric.
It seems to have a decent result, no, Anita?
Yeah, so it looks like very mild AI, and in fact, it actually looks quite good. It looks a lot less asymmetric than it did before. I would say it looks a lot better expanded. If you look at the hemodynamics, if you keep in mind our LV EDP prior to the valve was between 15 and 17, we haven't budged. We're again at 15 to 17, and so I take your point, Harinder. I mean, I think my initial philosophy was to post-dilate, and maybe we still will, but I do think it's important to evaluate the hemodynamics and decide if that really is going to be the case or not. How many people would post-dilate this? You can see there is a bit of a gradient as well. We have a great mean gradient of 13. So how many people would think that post-dilatation should be done? How many of you would just leave it as is?
So who want to post-dilate? Who doesn't want to post-dilate? I guess.
I think we would still wait.
Yeah.
I think there's maybe more few N rates for post-dilation.
So there's more people who would post-dilate or less?
More, but it's split.
Hi, Anita. This is Nico again.
Hi, Nick.
Hi. The result is good. Patient's going to do well. 80-year-old gentleman, he's going to come out and he's going to feel well, even if you leave him with this mild AR, and it might even get better over the course of 12 months. But it's just to bring up the discussion point, when we go into younger and lower risk patients, I would be interested to see that the REO caudal view of this valve, if it looks like
we'll try to do that for you.
Yeah, if it still looks like a pancake in some ways. Probably in the future in younger and lower risk patients, I think we it's a balance between post-dilating and injuring leaflets and, staying with an elliptical or non-circular valve with potential leaflet redundancy and pinwheeling of the leaflets.
So here you go. This is our Cine. This is as REO as we can get without doing a knockout of our echocardiographer. But this is an REO 32 caudal 17, and I agree. It's still looks better than it did prior to deployment. I think you would agree. But again, you do see the frame is constrained at the level of the annulus.
Yeah, Nico. What's the downside to post-dilate here in your mind?
We don't have any at the moment. There's been studies looking at whatever long-term durability we have, or the acute results after post-dilatation, and we don't have any untoward effects other than potentially increasing the risk of stroke and pacemakers.
Well, the other concern is anatomical. If your valve is already very high, and now you're post-dilating. You have some concern about pop-out.
Tu juste vérifier le
I don't
pace,
think you
s'il te
have
plaît,
any
Dr.
concern
Taillefer?
with pop-out in this valve.
Peux-tu vérifier le pace?
217 la CT.
Perfect. So I take your point, Nick, and I agree. I think hemodynamically the AI doesn't seem that significant yet. We're still waiting. The EDP hasn't really budged. I guess what's bothering me is also that gradient that we still have of 13 and seeing that it's obviously constrained at the annulus. So my vote would really be to post-dilate it. So we're going to verify our pacemaker and we are going to post-dilate this. So.
Anita, I have a question for you, Jean-François Gobeil. I'm not familiar with the Evolute system, but as for post-dilatation, how do you choose the size of your balloon? Do you go with the area of the valve itself, the longest diameter? How do you manage to decide?
So, the dimensions of this valve are 20 by 28. So, if we take sort of the mid-range of that, it's a 24. So I've opted for a nucleus 25. It's 4 centimeters long. We will rapid pace. The nucleus doesn't seem to move that much. Unfortunately, we don't have access to the true balloon, which is probably the better non-compliant balloon. The nucleus is not a non-compliant balloon, obviously. The advantage being it doesn't move so much. I don't know if anyone has a non-compliant balloon that they prefer that they have access to. Unfortunately, we don't have the true balloon, but in the absence of that, we're going to go with the nucleus 25. And again, just kind of based on what we think the mean, and we're not going to, blast the hell out of this thing. We're just going to, inflate it to make sure we can get better apposition and make it a little bit less asymmetric.
Anita, it's Benoit Dano. At this point, is there new conduction abnormality from what we can see?
Well, I mean, he had a bundle branch block. I don't see anything worse than that. He hasn't gone into complete heart block, so that's a very good point. Certainly with the valve implantation, we didn't see any heart block per se.
Yeah.
We're going to see now with the post-dilatation if he goes into heart block.
So that was the point. Nico was saying, he's an 80-year-old guy. He's probably going to do well even if you leave, a small amount of AI. What's your take? What do you think is the risk of putting him in complete heart block, doing a post-dilatation in this Evolute R?
It's a very good point, and I think it's definitely not insignificant. I mean, this is a man with baseline conduction system disease, particularly a left bundle branch block. His PR interval was longish, but certainly still normal. I don't think it's an insignificant risk, but I guess I'm trying to weigh the risk of the pacemaker with just trying to give him a bit of a better hemodynamic result. I think all of that is very debatable. And we certainly see less permanent pacemaker with Evolute than what we saw with core valve. But I mean, judging by the amount of calcification he has, et cetera, I think he is high risk for heart block. So I don't disagree with you, but I think we've made our decision. We're gonna post-dilate.
Anita, this is Nico again. Sometimes it's nice to post-dilate in that view where the valve looked constricted, so you can actually see it expand and do sort of an eyeball test of when to stop expanding the balloon. But sometimes you don't really need to, go all the way to 25.
Right.
Just to prevent annular rupture or just other complications.
So we do this by hand. Obviously, we don't use an inflator. We just inflate by hands. I think that's a good point.
What view are you in right now?
We're still in the LAO. Peux-tu mettre le pace à 120, s'il te plaît? Pacing on. J'ai pas de pace, Dr. Taillefer. Oui, pacing on, s'il te plaît. 140. Okay. Balloon up. Balloon down. Pacing off.
Is it on purpose, Anita, that you use a balloon that has somewhat of a dog bone shape?
Well, I just find it
rather than
moves
a
less.
straight
That is
balloon?
the nucleus balloon. It does tend to move a little bit less. I would argue that does look a bit better, but we're going to go into the RAO view just to see. Peux-tu juste descendre un peu, Patrick, pour voir?
I think the expansion is better, huh?
Yeah, I agree. But we'll see in the other view. Attendez. Ouais, vas-y.
All right, so Anita, you can potentially go back to your. Can you give us maybe a gradient? It's going to be probably the final the final feature of your case,
Your
maybe.
balloon's not down.
We need to go for Live in a Box soon.
Okay, well, we're going to have to let you go. We're still just trying to get our balloon down. So I won't have time probably to change out the pigtail and show you the gradient, but we'll let you know.
But no, go ahead, please. I think it's
Okay.
maybe an echo, maybe
Vas-y,
assessment
Anna.
also of what you.
Okay, but we'll let Patrick have a look. We'll
Yeah.
see an update.
So still no AV block, I guess.
Oui, juste montre pas le ballon. Il rentre. Ouais, là, c'est bon, reste ici. No, still no AV block.
You okay?
This is one.
Okay, wait. I just added some more negative suction on it.
So Patrick, if you want to just describe what you see.
I'm just looking around.
Can we see the echo, please? Okay, thank you.
It's really weird.
Okay, attends.
So you're
Ça
live.
repart.
I would say the AI is,
Montre-moi un peu le ventre.
if we go,
Looks good.
Faut que je vois le bien.
See, the
harder
valve
to
is a
find.
lot more symmetric now, I guess.
I don't
and it's
understand.
better than it was. Yeah.
Can you measure a gradient by echo for us, Patrick?
I'll try. Yeah, so the AI is quite better. I would say it's trace. Hard to find.
Cool. And can you quickly? So are you going back with your pigtail now or not?
No,
not
it's
going
going
to be able.
because the
Okay,
balloon's
no
having
problem.
trouble coming down.
Just say maybe quickly how are you going to manage your pace, because you put the screwing pacemaker in place.
Yeah, so there is a screw-in lead in place, and the plan now is going to be to have the patient reevaluated by EP. So they did do a baseline EP study yesterday, and we usually go to them for insight to decide whether this patient's going to need a permanent pacemaker or not. Then that brings up the interesting issue with the TR. If he does need a permanent pacemaker, what do you do with that? Is a leadless pacemaker better, just to not, to further worsen his TR? So we're going to discuss that with the EP team and let them decide.
Cool.
Anita, there's
Very nice demonstration, Anita and Jean-François and Raymond. It was perfect result, I think, at the end. Well demonstrated. Thank you very much. I think we are going to leave now to show here live in a box. So thank you.
Thank you.
Feel free to share more things later in this afternoon, maybe your final gradient or how it goes with your vascular access.
Perfect.
Thank you.
Bye.